Hey, we spend roughly 1/3 of our life sleeping. And when we don't sleep well, the other 2/3 of our life start to suffer. Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. This is Open Mics with Dr. Stites. Bad sleep often comes down to bad habits, but sometimes it's truly a medical problem. Today, we're meeting with a man who had sleep apnea. Ron Hoffman had no idea that he stopped breathing every night. Now he's sleeping remarkably well with an implant that zaps his tongue. Ron Hoffman is here with us today. So Ron, did you sleep well last night?
Yes, I did.
All right. Did your tongue get zapped?
Yeah, I'm sure it did.
You don't feel it though, right?
No.
All right, we're going to learn more about that whole story and the implant that goes along with that from Dr. Christopher Larson. He's an otolaryngologist. I can say that pretty fast. Also known as an ear, nose, and throat doctor. He specializes in head and neck surgery and has a special interest in conditions like sleep apnea. We also have a sleep expert. Dr. Damian Stevens is a sleep medicine specialist. He's the director of the sleep lab here at the health system, and he's my sleep doctor. So today, we're going to have a conversation about sleep apnea. Ron, let's start with you. Before you knew you had sleep apnea, you were having some serious problems that you could not explain. Tell us about those problems.
Well, besides having sleepless nights and stuff like that, I eventually went on to a BiPAP and a CPAP, and I tried those, and I tried different masks and everything else, and they just didn't work for me.
Were you exhausted and tired?
I was.
Yeah.
And then ultimately, I couldn't get used to them, so I stopped using them completely for about 2 years.
The different kinds of devices.
Yes, lots of them. Yes.
Well, you know, a lot of people say that they have some memory difficulties when their sleep apnea gets more severe. Did you experience that?
Yeah, yes, absolutely.
And somebody said maybe you had early Alzheimer's, is that right?
I don't know that they said that, but
my wife thought that. So, you know, because I had this terrible start. I mean, I could snore a house down. And my kids were like, Dad, you got to be in a different tent from the rest of us when we went camping. And I said, yeah, but do you ever have these kind of funny, and when you have sleep apnea, you sort of stop breathing in the middle of the night. Sometimes you kind of choke on your breath. Maybe you have these long periods where you're not breathing. I said, Sandra, do I have any of those? She goes, no, you're fine. And then one time she took a video of me, and I had every textbook symptom. Man, I was jerking awake. I was throwing my arms, my legs were kicking. I wouldn't breathe for a while. I'd be snorting. And I was like, Sandra, has it really been that? Are you just trying to get rid of me here? That's pretty bad. I had to go see that guy. Man, it was pretty severe. How did you find out you had sleep apnea? Did your wife shoot a video of you, or did she just wait for you to just kind of, you know?
I have a bad memory, but I can't remember what started it, but I did have a friend of mine that was a nurse who would use dental appliances, and I tried that, and I just tried everything that was out there, and nothing really worked for me.
And you were snoring really loudly. Is that what came along with that?
Yeah, kind of. It used to wake my wife, and she wasn't happy about that. Didn't wake me, but yeah.
And you're one of those people who really struggled with the different masks. Once they made the diagnosis, you went through a sleep study, and you tried different masks, and you just couldn't find one that suited you. You were talking a little bit about that before the program started. Tell us a little about it. How hard was that journey?
Oh, it was. I mean, I got one machine and then different mask, and that didn't work. And then they gave me a different machine and different mask for that too, and that didn't work. And finally, I just got tired of doing it. One of them actually had an alarm on it, that if you tore the mask off, which I would do at night, and the alarm wouldn't wake me, but it would wake my wife, who in turn would wake me.
Well, that was very special of you to share this with her. That was very kind of you.
I'm a giving person.
There you go. Well, you know, it takes all kinds, I guess. So Dr. Larson, folks told Ron his sleep apnea was life-threatening. How bad was it?
Yeah, so to qualify for this device, you have to have moderate or severe obstructive sleep apnea, and that moderate is defined as more than 15 events per hour. So I believe Ron was in the moderately severe range, so slightly less than 30 events per hour. But that means, you know, every couple minutes he was kind of starving his brain of oxygen and struggling to breathe.
And so you kind of wake up, right? I mean, you think you're asleep, you know. Yeah, that's a great sound effect. You guys want that visual again? I can snort like a pig again. But you just sort of pop up and you wake up and then you go back to sleep. And you don't really wake all the way up, but it means you really don't get good sleep.
Right. Yeah, a lot of patients will present even with atrial fibrillation or an abnormal heart rhythm. They can, the most common presentation is loud snoring and fatigue, or just falling asleep during meetings or even when driving, heaven forbid. So yeah, that's usually what we see on our end.
So Dr. Stevens, help us connect these dots. Why is this thing happening? Why do people not breathe correctly at night? It would seem like our bodies were built to breathe right. What happens?
We really don't understand the physiology entirely. Like you said, you'd think that natural evolution would be you keep your airway open when you breathe at night, because that's not normal to close. It's about 80% of patients are overweight, but that still says at least 20% are of a normal weight. We think it may be brain chemistry to keep your airway open, the nerves that go to your airway itself. Some wonder if it's a, quote, neuropathy, meaning the nerves don't keep your airway open appropriately. As we get overweight, there's fat deposition in the airway, all those different things. So they can occur.
So as you go through this and you start trying to make these diagnoses, what are the classical symptoms you find in patients? I mean, I can snort again if that helps you. I can give you another.
Like Dr. Larson already referred to, snoring, about 80-90% of patients are going to snore. So if you have no snoring, the chance of apnea goes down a lot just with the lack of snoring. But once again, you can't exclude it entirely. This disrupted or fragmented sleep, waking up feeling unrefreshed. Some patients have headaches. One of the more common symptoms, especially in men, is they're going to the bathroom 6-8 times a night, and it's that kind of disruption of the sleep, and because they're kind of awake, they end up going to the bathroom, and I have some patients that goes to 1 a night from 6-7 times a night. As Dr. Larson mentioned, sleepiness while driving, this kind of lack of ability to concentrate. So it can manifest in quite a few different ways, but snoring is one of the most common, and if you have a bed partner, witness apneas too, where the bed partner will actually see what your recording showed, that the patient's not breathing.
I remember in my clinical practice one time I had a patient, it was a long time ago, who was a bus driver for kids, that's a scary thought, and had severe sleep apnea. Now, he met the more common things where he was really overweight, but he couldn't do his job as a bus driver. He kept falling asleep while driving a bus full of school kids, bad thing. So we had him come in, he had really severe sleep apnea, we did a sleep study, and then we put him on a CPAP, and he felt he was a completely different person the next day. His wife called us and said, "You have to get this device immediately. I got my husband back."
Yes. And that's actually become a common rule for the DOT, Department of Transportation. They are often screening employees now, truck drivers, bus drivers, for sleep apnea. And I'm probably seeing a patient or two a week that was sent directly because of that screening, the concern for an accident, injuring themselves, injuring others.
All right, Ron, we interviewed you and your wife years ago before you got this implant. So the masks didn't work. And then this new technology came along, and we're going to talk about that, but first, let's listen to one of her comments.
The first device he got was almost like sleeping with Darth Vader. The noise level and everything, it was so loud, and it would go, there were alarms, and they would go off. And so Ron would never wake up because they gave him things to sleep to be able to keep it on, but he would put it up on his forehead. And so alarms and lights would be going off, and I'd be waking him up and saying, "It's on your forehead, Ron," or "You've taken it off." And he had no idea. He was so sound asleep from the medication they'd given him. So I was getting sleep deprived with his machines. And that went on for years, and he just could not keep the mask on.
Bam, 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 ba-da-dum. So you were Darth Vader, huh?
I was.
And your wife, your poor wife, man, that was tough. So, okay, now we've got some video from your surgery with Dr. Larson. Dr. Larson, tell us how this upper airway stimulator implant works.
Absolutely. So there's 3 components. This first part, there's an electrode that's placed on the hypoglossal nerve. The hypoglossal nerve is the nerve that moves your tongue, and my job is to get that on the branches that stiffen and extend the tongue. There's also branches that help us swallow. So kind of the technical role there is to get it on the right branches of the nerve, and then that's tunneled to the chest where there's an IPG, or more commonly referred to as a battery or a power source. And then the third component is a sensor that's placed between the ribcage muscles, which monitors respiratory effort. And so the 3 are connected, as you can see, to that pulse generator or that battery, and then communicated with a handheld device to turn the device on and off when needed.
So what kind of complications come about from these? And can you say still go swimming and walk through an airport? You know when I'm talking about screening.
Yeah, no, absolutely. I get those questions all the time. At the time of surgery, certainly with any implant, you want to be extra careful about infection, so we do everything we can to prevent infection. Placing a sensor between the rib cage muscles. There have been reports of pneumothorax, which is a collapsed lung and can be very serious, but that's extremely rare. Less than probably 0.5% in the literature experience either of those complications. Sometimes by putting the electrode on the branch of the nerve that moves the tongue's a little clumsy or a little weak. That's not super uncommon, maybe 10 or 15%, but almost always resolves within a couple weeks to up to maybe a month after surgery. And I've never seen anybody with a long-term paralysis or weakness in their tongue function. So.
Okay, so this is a pretty big deal. Ron, what's it like sleeping with the stimulator?
Oh, you turn the thing on at night, and I go to sleep, and that's it.
And you have a remote control you brought with us. Show us that.
Yep. You hit the button, and you hold it up here, and it turns the thing on.
Yeah.
And you can pause it by hitting it again, and that gives you about, 15 minutes, or you can turn the thing off with this button down here.
So that's pretty cool. Does it turn on your TV as well?
No.
Just does the stimulator. You don't have to worry about it turning on something else in the room or making funny things or making funny sounds. Okay, well, that's good. So we've estimated already, we talked a little bit about how people know they have sleep apnea. 23.5 million Americans have that. Dr. Stevens, short of having to have a surgery, what else can you do?
There are several other options, and just kind of to take a step back, studies over the last 30, 40 years have shown only about 50 to maybe 2/3 of patients, 50% to 60% are able to use CPAP long term. That's why for all those years that was really the only true option. Now in the last decade or so we have several more options. One is an oral appliance, and that's kind of like a bite guard. But it has an upper and lower plate, and it's a custom fit, and it either has a hinge, a screw, a rubber band. Some you turn a half a turn a night for a week or every 2 weeks, and then it slowly pulls your jaw forward that's what we refer to as an oral appliance. Then some patients, about 20%, will have apnea only on their back. And if you have it only on your back, you can wear a positional device. One of the more common ones used is a tennis ball shirt. It has a tennis ball literally between the shoulder blades and the back of the t-shirt. Therefore, when you lay on your back, you feel that you roll on your side. There's a cummerbund thing that has some inflatable balloons in the back. So any device that keeps you off your back. But once again, that's only about 20% of patients, maybe even 15%, that only have apnea in their back. But those are a couple other options. There are other surgeries that Dr. Larson sometimes has done in the past. The most aggressive form is where we literally break the jaw and advance the lower jaw. That's a major, reconstructive surgery, but we will occasionally have patients undergo that procedure also.
So really, a lot of this is about the back of the throat, which
Yes.
at night relaxes.
Yes.
And normally our body knows, our brain still is pretty asleep, but it does send a little stimulation that when you time to take a deep breath or a breath at night, you get a little thing and a note to self, so to speak, that your airway opens up so you can take that breath and then it relaxes.
Then it relaxes.
But in some people, it doesn't open up.
Yeah.
How come?
And like I said, it's either the vast majority, it's related to extra weight. We think fat deposition in the tongue itself and around the throat itself is the control center within the brain not sending enough signals to keep the throat open, is what some people believe. The nerves, like Dr. Larson's attaches to the nerve to keep the throat open. You would think the natural body response would be you send more signals to keep the throat open through that same nerve, but the body in some patients just does not have that reflex to keep the airway open. So we truly, and like I said, there's even studies that show that the patients that are a normal weight, the apnea is more common in that family, so that's why we think there's some genetic factor that also is playing a role in this, because why do some families at a normal weight have no apnea at all and others will? So there's some genetic role we don't entirely understand either.
Yeah, my brother had the same thing, and he and I are both about the same body mass, and it's just like, holy cow. Okay, so breaking a jaw helps fix it?
Full disclosure.
Are you?
Yeah, full
You are
disclosure.
related to
I don't
Darth
do
Vader.
that surgery. One of the more commonly known otolaryngology or ear, nose, and throat surgeries for this procedure is uvulopalato-pharyngoplasty, which is certainly a mouthful, but a UP3. And that's generally effective when patients are thinner and when the tonsils are larger. So basically, if the tonsils, they're pretty easy to remove. If that's a big contributor to the airway obstruction, that surgery can actually be fairly successful. I'll also do a hyoid suspension surgery where we suspend the hyoid bone to the jawbone with a couple bone-anchored screws. And so there are other surgeries that generally those surgeries are more painful and less consistently efficacious for patients. So, the kind of final surgery until at least Inspire was called a maxillomandibular advancement, where actually in a controlled setting, the maxilla, the upper jaw, and the lower jaw are both fractured and pulled forward.
You're making a dentist visit sound really good right now.
Yeah, right.
That's what you're doing.
Right.
All the dentists in the world, thank God he's talking about that. It made me look better. All right, so most people that don't have apnea and they don't always get a good night's sleep, what causes all that?
There's
Besides
so
organ
many
gymnasium?
factors that go into a good night's sleep. Everything from medications to stress, anxiety, depression affects your sleep quality. The environment, it's noisy. There's other things going on. A lot of that is what we call sleep hygiene. And by the word hygiene is simply keeping your sleep clean. Patients go to bed at 9 o'clock one night. The next night they're up until 1 in the morning because they're watching a movie. They're out with friends. Alcohol plays a role in this. Caffeine in some people can play a role. So there's so many different factors that go into that. Irregular bedtime, wake time. There's just so many relevant factors to that.
So this thing about separating screen time and bedtime, tell us what that means.
That's a lot related to your circadian endogenous cycle. The release of melatonin we have found is affected whenever you have light exposure later in the evening. That's something that, obviously 100 years ago was not relevant, but even in the more recent years was not typically that relevant in most people because they didn't go to bed with the lights on. But now that you're on your phone, you're on your laptop, you're on your iPad in the bedroom, we have found some effect with that also, light exposure, and that's why many of the devices now may have a setting, for lower level lux. It's the lux, the strength of the light that really has that effect.
So what you're telling me is that my decision last night to stay up and watch with my wife the last episode of Ted Lasso that didn't drop until 11 p.m., and thank God I did. I loved it. But that may not have been the best choice for my sleep hygiene.
There's so many factors, like I said, and that's the modern society with lights, with doing these things that late in the evening that we didn't deal with. They even think that years ago, whenever you went to bed when it was dark and you got up when there was light, some nights there were 10 or even 11 hours of darkness. People used to sleep 3 or 4 hours, wake up for a couple hours in the middle of the night, go back to bed and sleep another 3 or 4 hours before they get up in the morning. So your total sleep time was interrupted because there was so much dark time that you would actually sleep 3 or 4 hours, awake a couple, go back to sleep for 3 or 4 hours.
So those really long Alaska nights in the middle of the winter would have been an interesting challenge. All right, now you've also studied folks in the Mennonite population and the sleep habits of folks like that who don't use electronics. Talk to us about that.
That was around 10 years ago, so it's been quite a while. What it really came from was, that was about the time smartphones were becoming commonly used, and we were wondering, does this really have that much an effect? The issue is, to ever get at that effect, you're going to have a group that has that exposure and a group that doesn't. Well, you're going to be pretty hard-pressed to tell a group of teenagers you're not going to have your phone at night. So what we kind of thought, who would maybe not have their phone, was a Mennonite population. So we did find, we only had around 20 teenagers and around 40 to 50 adults. But we did find that, yes, there was clearly an effect. But what's interesting, even then, 10 years ago, at least 15% of the children in that population still had a phone in their bedroom at night.
Well, there you go. So phones may not be the best thing to help us sleep. All right, so there's a lot we don't know. Why don't we know more?
The big thing about sleep is it really has never even been a specialty in the last 20, 30 years as far as a specialty in medicine. So research into sleep, sleep diagnosis, sleep disorders, when you compare to heart disease, lung disease, all these other diseases, sleep is a much more recent field, specialty. of medicine compared to all these others, and that's why it's such a new field still. Insomnia, especially, why people have the difficulty falling asleep, staying asleep, the neuropharmacology of sleep is still pretty new to, and that's why there's so many unknowns about sleep.
All right, well, don't get tired, and we know you're not tired of this topic, so we're here to answer your questions. We don't want you to fall asleep on us. Send them those questions to us. I'm pretty cool there. That's pretty cool, a little clever. Send us your questions on YouTube, Facebook, Twitter, email, the Medical News Network. Let's check in with the COVID count with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control here at the healthsystem.coc.
Hi.
The numbers are still low. That's great. Are we done talking about COVID?
Yeah, I don't know. I mean, certainly we know Dr. Stevens is a sleep expert, but I was falling asleep right here, and I still got my coffee, and I just woke up. So,
You were watching Ted Lasso last night, weren't you? Me, I don't know.
But to his credit, working with Dr. Stevens is great. He was one of our docs here at the health system that went out to the Northeast, to New York, to provide his services when the country was in the throes of the COVID pandemic very early on. Right now, times have changed, though, luckily and thankfully. We have very low numbers in the hospital. We have single digits for active infections, 17 total, but 7 active, 1 in the ICU and on the vent as well.
Yeah, we got down to 3 though, so we're up a little bit. I think that's just the normal. That's where we're going to be probably for years to come, Hawk.
Yeah, well, I think so, but I think, we have some topics about new, therapies and therapies that we already have. We also have to remember this disease now is really becoming a disease of certain populations, i.e. the elderly, the immunosuppressed, and so we can't be myopic in just thinking that because most people's everyday lives are not affected by COVID, there are populations that are still affected, and it can impact them significantly.
No, that's absolutely true, and we have to remember that even though there's not as much, there is still patients who are developing long COVID, and that is a huge complication of this disease that we seem to talk about for a while, and it's like, well, the numbers have dropped down, we don't talk about it as much anymore, but it's really a severe problem. We got a number of people I follow right now with long COVID. It's tough, folks. Now, fortunately, the FDA has moved to full approval for Paxlovid to treat COVID-19. Not a huge surprise. No longer under an emergency use declaration. So just more proof of the efficacy, Hawk, of Paxlovid.
Yeah, absolutely. And we know that there are still U.S. government supplies of that. They bought a lot of courses of that drug for people, so we are still using that. Once that happens and we get through that supply, there will be a cost. But for the most part, what I understand now is a lot of people are able to get it for free because of the government supply, which we still have, I think, 10 million or more courses that are available through the pharmacies. So it is very important, especially in those high-risk groups. It does significantly reduce your chance of hospitalization and severe disease.
Yeah, but it's really been a good therapy, and it doesn't. I mean, in fairness, it has side effects and it interacts with a lot of medications, so it's not for everybody. And for a while, we were using monoclonal antibodies, but then the virus shifted a little bit, and the monoclonal antibodies weren't active anymore. But there may be some emerging evidence for some new antibodies. Talk to us.
Yeah, and this is why, because of what you said about Paxlovid and the drug interactions, some of the side effects, this is why the monoclonal antibody therapies are so important. And you had recounted anecdotes about people, once they get finished with that infusion of the monoclonal antibody, they feel so much better almost immediately. There is research going on, although there is not really a lot of funding for it. So it is moving a little bit slower pace than before, but there is research going on into developing those therapies, those monoclonal antibody therapies, those ones that would be resistant to those changes in the virus and those changes in spike protein. So we are optimistic that those will occur, both for treatment, but also, as we talked about, those immunosuppressed populations or people who may be at higher risk of severe disease, getting that as a prophylactic, maybe once every 6 months, so that you can have some circulating antibodies in high quantities, so that you can help prevent that infection, but also that severe disease. So I think we are optimistic that some new monoclonal antibodies, therapies, and prophylaxis will be coming out, hopefully within this next year.
All right, approximately a very big deal.
Yeah.
All right, Alexis Del Cid is with us today. Good morning, Alexis.
Good morning. We have so many questions and comments coming in. Definitely sleep hits a nerve with a lot of people. Joellen, one of our viewers, writes, it's difficult to know if you snore if you don't have a partner. So I have a question for Joellen. Is there any app that you doctors love that you could recommend for people who don't sleep next to someone if they want to know if they're having sleeping trouble?
Great question, guys.
There's several different apps that patients will bring in. Well, back to Dr. Steitz's story about the recording, probably about once a week I have a bed partner or spouse that actually brings in that recording and shows it to me.
That was great.
Yeah, quite often I'll ask, if you're traveling, hotel room, friends, family, but like you said, if you don't have a bed partner, it's difficult to tell. If there's any other signs in that situation, a family history in that situation, or other hints, we typically will just go ahead and do a home sleep test. It was a little bigger deal years ago when someone had to come into the sleep lab and do a full night recording. The pain of coming to the lab, the wiring, the expense. Now a home test is such an easy, simple test to do. Most insurance doesn't even require an authorization. So the vast majority of the time, if there's any suggestion at all, we just will go ahead and do a home test. But almost all those apps that record snoring would be useful, would increase, the suspicion if that was, positive.
But the home test sounds like a great option. Yen Liang wants to know, do older people always have sleep apnea? Because among my friends, the older they are, the more they seem to snore. Do patients always have to wear an oxygen mask while sleeping if you have sleep apnea?
Wow, that's I don't know. I guess I'm in that older degree.
Define older.
Yeah,
Well,
watch out for that. Steven's in about the same age, though. He's old, too.
Here's what's interesting about that question. It has been shown in almost every study, every decade of life, 50s, 60s, 70s, there's a higher rate. Now, do you get to the point where maybe the normal range is not the same if you're in your 70s or 80s? We've never completely answered that question, but every study that's looked at it has shown every decade of life there's a higher incidence or rate of apnea. We don't know for sure if maybe we should use a different normal for a 50 versus an 80-year-old. But it definitely has been shown as we age there's a higher rate. As far as back to the question of the oxygen mask, that's typically what we call a CPAP mask. The CPAP machine is nothing but an air compressor attached to a hose, attached to a mask, so it's not oxygen necessarily, it's just compressed air that uses that compressed air to keep your throat open. So it's not necessarily an oxygen mask, it's a CPAP, and what CPAP stands for is continuous positive airway pressure. So that's what the CPAP actually stands for.
Push a little air in the back of your throat to keep things open. And I use that. I think it works great. I don't like to sleep without it.
Dean Huff has a question. Dean would like to know, does a deviated septum contribute to sleep apnea or blood oxygen levels?
Dr. Larson.
Yeah, that's an excellent question. Generally speaking, nasal surgery does not change the severity of obstructive sleep apnea, but in fact, sleeping or breathing well through our nose does improve subjective sleep quality. So anytime we do a nasal surgery, I do a septoplasty on patients, we give them a nasal obstruction septoplasty effectiveness nose, kind of groovy nose questionnaire, and one of the questions on there is the quality of your sleep. So if you don't breathe well through your nose, you're generally not going to sleep as well subjectively. So it's a little bit of a tricky question, but.
And I will send patients to Dr. Larson specifically for that reason also sometimes if they can't tolerate the CPAP. If it's an issue with getting air through their nose and he opens their nose with the surgery, then many of those patients actually can tolerate CPAP better also.
Okay.
So it's not necessary to treat or cure the apnea, it's to allow them to tolerate the CPAP.
Absolutely.
Angela Yink-Saylor has a question. She wants to know, this is a good question, does sleep apnea have an effect on the heart?
Oh boy, or boy does it.
So the main thing that we have found, and this is now going back almost 30 years, studies, what they did in Wisconsin is they followed a large group of patients that were diagnosed with apnea, but they didn't treat half of the patients, and the others, they followed them over years and would do a study every few years. And sure enough, if you had apnea, the rate of patients developing high blood pressure was at least 2 to 3 times higher than patients that did not have sleep apnea. So that's the strongest association heart-wise, is there's a higher rate of high blood pressure in patients that do have sleep apnea. And they took into account whether they smoke, their weight, alcohol use, all these other factors that are related to high blood pressure, and those are the best studies that show the relation between sleep apnea and high blood pressure.
Has there been some data suggest that you also can develop irregular heartbeats when you sleep?
Atrial fibrillation, you've heard of that. There seems to be some association there. The higher the rate of apnea, the higher the rate of atrial fibrillation. So I also will see a patient or two a week from the cardiologist specifically for that reason also.
So, and a little bit of higher rate of stroke and heart attack.
Yes, that's been looked at also. It seems to be the rate in even other cardiac complications when patients have sleep apnea. Some of that becomes difficult because if you have are overweight, you may have diabetes, and is it the sleep apnea or the diabetes that may increase some of those risks? But it seems there's several diseases that are at least related, if not caused, by the sleep apnea.
If I could just say something, one of the best studies looking at cardiac events, if you will, in sleep apnea patients actually found no association. It was a great study in the New England Journal of Medicine, but in the treatment group, those that were treated with sleep apnea, the average use was 4 hours a night. So, I mean, again, therein lies the problem that a lot of patients, put it on when they go to sleep, but they don't keep it on. So if you're not treated through the night, are you really fully treated?
Yeah, you're probably not, right? Because you're still getting that occurrence of those bad events. Alexis.
I have one question. I've always wondered this. Does when it comes to snoring, is it possible for someone to snore like a freight train but still be getting a good night's sleep? Or is snoring a sign of a sleep disorder?
Certainly, one of the most common signs of a sleep disorder is snoring. That being said, a lot of people snore pretty loud and don't actually have apnea. So that's why a home sleep test as a screening device is a great option for people to kind of know where on that spectrum of severity between, we call it simple snoring, certainly not simple to the bed partner, but between simple snoring and severe sleep apnea, because most of the high blood pressure cardiac complications have been more associated with moderate and severe sleep apnea, which is why we get more.
If you do a sleep study on like the next 100 patients that come to your office and say they snore, only about 50% will actually have sleep apnea.
50.
So yeah,
50%.
About 50%. Half the patients don't. But there has been a couple studies, the loudness of the snoring and consistency every night versus every other night, and it's all, rattle the walls kind of thing. There is some predictive power, meaning the louder you snore and the more consistent, it is more likely you are to have sleep apnea versus those patients that just kind of occasionally and maybe it's only on their back.
Ron, were you a freight train? Did you snore that loud?
I snored, but I was asleep during it, so I don't know.
You don't know, but
my
your wife thought you were.
Yeah.
That was it. She thought you were Darth Vader before you were Darth Vader, is what I'm hearing. All right, Alexa.
I have one more question from Joellen. She has a follow-up question. Joellen wants to know, if most people are overweight, how do you sort that out with high blood pressure?
That was kind of back to the statement I made before. What they did is they followed those patients, and whenever they corrected for the BMI being the most common way we assess or grade the severity of being overweight, they still found this effect, meaning whenever they corrected for the BMI, they still found an association between high blood pressure and having sleep apnea.
Interesting.
And I'll just tell you that getting treated is just amazing about how much better you feel. And I think you'd say the same thing.
Oh,
you probably feel so much better with your sleep device.
Absolutely, no question about it.
We're fans, Alexis. Hey, one other thing. If you have this spinal cord stimulator and this or a pacemaker, can you still have this sleep stimulator?
Yes, absolutely. We were part of an original study. We started implanting the hypoglossal nerve stimulation system in the fall of 2016, and so that was a very common question. And earlier you actually asked me the question about going through radar or X-ray detectors, metal detectors at airports. That's not an issue. One of the initial issues was MRI compatibility, so if you needed an MRI, but that's been worked out now. They have FDA clearance because enough people have gotten MRIs that have the device, and there were no bad effects. So, but yes, with spinal cord stimulators, with pacemaker defibrillators and pacemakers, you basically put the implant on the opposite side. So most people have a pacemaker on the left. We put the implant on the right. Occasionally I find patients that have had some sort of breast surgery or neck surgery or whatever, like to hunt a lot if they're right eye dominant, and they're bumping into the pulse generator. Sometimes we'll put them on the left side. So excellent question, but definitely compatible.
We actually described the first patient that had a pacemaker and the Inspire, one on each side.
Yep.
All right, so they're like dueling makers.
Right, yeah, they're
all right.
fully bionic.
So how big is the generator? Like compare it with Ron's sleep remote here.
Yeah, so it's, I don't know, it's bigger than a quarter, but that video was actually the first first iteration or first generation, I guess, of implant, and so it was certainly larger than currently what we're using. It's probably about, I don't know, quarter inch.
So it's just a little bitty thing.
Yeah, it's pretty small. I mean, in thinner patients with a shirt off, you may see, slight little bump, but certainly wearing a t-shirt or whatever, you would never know was there.
All right, excellent, man. This has been a great conversation, and there's one in here that do sleep doctors follow their own advice? Do y'all sleep very well?
I've been given the gift of sleep personally. I mean, my bed is the pillow, and I have no trouble falling asleep, staying asleep.
I do too, and I like the way Chris described it. It's kind of the gift of sleep, and there's some patients just kind of are destined to sleep well, the insomnia and the other issues, but others, just struggle with one of those, apnea, the insomnia or something.
One thing we haven't hit on is the level of stress in life. If there's a lot of stress going on, in the middle of COVID, for example, I didn't get a lot of sleep, and I couldn't sleep very well. But man, most of the time I can go to sleep like a baby. But that's how we work. We're supposed to do that. But there's so many things in your life, whether it's stimulation from a television set, or your phone, or too many access and your phone going off all night, or stress. I mean, stress plays a major role in sleep disturbance.
Absolutely.
All right, this has been a great discussion. I am grateful to all of our guests for being here, even Darth Vader. He doesn't have a light sit with him at the moment, but I wonder about that sleep thing he's got right there, whether that's going to pop out with one. Let's get final thoughts. Dr. Stevens.
Appreciate good sleep when you have it, and if you don't, always practice good sleep hygiene. And if you have issues, don't give up. The biggest thing I would have to say, you got a friend, a family member that's struggling with CPAP, just let them know that we do have several other options. So rather than stay at home and not do anything about it, we have a lot more options than we did 20, 30 years ago.
And if you have somebody who snores a lot and has some funny snoring, go tell them to be tested, because man, you feel better. Dr. Larson.
Yeah, I echo those sentiments. I mean, it's pretty cheap and easy to get a home sleep test. So if you have concerns, or if you're tired, you have morning headaches, you have some of the things we talked about today, get yourself screened, and what you may think is no big deal and simple snoring could actually be severe sleep apnea and likely impact the length of your life. There's a study from years ago basically looking at one outcome, and that's survival. No sleep. It was done in the VA. No sleep apnea, moderate sleep OSA, and severe sleep apnea. In just over 20 years, the survival curve is dramatically, less. Or
yeah, no, I mean, if you don't sleep well, you don't feel well, and right. it manifests itself in lots of diseases. Ron, final thoughts today.
I would just say that I had it in 2016. It's changed my life. It's changed my sleep patterns, and if you can qualify for it, I definitely recommend you do it.
All right, Doc Hawk.
Yeah, no, I think
he's got his cup of coffee right there.
I love my caffeine. Yeah, absolutely. I need it. But we are always asked, Steve, especially early on in the pandemic, what can we do to increase our immune system? Certainly, we've always touted, it's a good, healthy diet. It's not really those supplements that they push over the counter or on TV, but it's good, healthy diet. It is activity, and of course, we've always said sleep as well. So this has been a very good conversation. Sleep hygiene, getting the correct sleep and the correct amount of sleep is so vitally important. And as we just heard about the VA study, which showed that is crystal clear. So I think that is very important, and I probably need to go get looked at for CPAP as well. So
hey, listen, if you need it, you're going to like it. If you can tolerate it. Now, Ron had to go a different route, but man, for most of us, it is just so great. I want to say a special thank you to these guests. This is a really important program. We sometimes want to minimize the importance of sleep. We do have to remember, a third of our life is spent that way. It's when your body repairs itself. It's when memories are made. So many important things happen when you go to sleep. Don't let that slip away, and don't sound like Darth Vader. May the Force be with you. Thanks again to all of our guests. We'll be back tomorrow, and remember till then, faith, hope, science. We'll see you soon.
Ahead of Father's Day, we highlight one son's gift.
Because of that one child, I'm alive today.
I'm Jessica Lovell. On the next Morning Medical Update, faith gave a longtime police officer hope. Family gave him the gift that helped heal his cancer. Friday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.